So now we have a COVID-19 keynote from Dr. Kim Rhoads. Her background and scholarly work spans the full cancer continuum, including basic science research as a colorectal surgeon, research on the quality of care and cancer disparities, training in health policy at Harvard, and as the inaugural Philip R. Lee Fellow in Health Policy at UCSF. She had formal training in community organizing at the Center for Third World Organizing in Oakland, California, and community-based participatory research training from the UCOP California Breast Cancer Research Program. Welcome, Dr. Rhoads. How are you today?
Well, I'm feeling a little nervous following that panel because that was the bomb, and we definitely need to be, I need to be connected as we talk to people about self-care, like who's actually doing it. So thank you so much for inviting me. I'm really excited about being here.
Right. Wonderful.
So shall I go ahead and share my screen?
Please.
Okay. All right, so I'm excited to be here to talk a little bit about COVID, and you know, you heard my bio, it's got a lot of cancer in there, and that was originally where I started, but I think that the work that we've done in COVID, which really was initiated by our Cancer Centers Community Advisory Board at UCSF, is a demonstration of what we can do when we work together and when we try to include regular people as part of the solution, rather than, you know, maintaining the barriers of institutions know everything and should do all the work. So just to give you a little bit of background on COVID-19 and how it's played out in Alameda County, I'm just showing you here the cumulative deaths as well as cases in COVID. And I just really want you to make note of the numbers, because these are the numbers we're using as denominators. So these are the total number of cases at this point, a little over 350,000. And then the total number of deaths in Alameda County has been a little over 2,000. But when we break that out by race ethnicity, what you can see on the left-hand side here is that African-American people, even though in the beginning of the pandemic, we said, oh, Black and brown communities, and we were talking about cases, what you can really see is that there are a number of different demographic groups that have higher rates of COVID-19 infection. And in fact, African-American people throughout the pandemic have had the 4th highest rate of COVID-19 infection. So probably a little surprising for some people, but I think important as you parse out the data to try to figure out what are the interventions. Because when you shift over here to the right-hand side panel, what you see is that African-American people have been second in terms of having the 2nd highest mortality rate. And to be honest with you, for the majority of the pandemic, this used to be the highest mortality rate until Pacific Islander communities surpassed that somewhere late in 2021. So those were rates, but I want to really get at the numbers so that we can capture this issue that is, I think, quite different for African-American people. As I mentioned before, we don't have the highest rates. What I'm trying to show you here on this graphic is that in the orange bar, that's showing you the percent of the population for the particular demographic group that's indicated at the bottom. An African-American group is here, 3rd from the left. So we represent about 10%. I thought I heard 11% at the beginning of this session, but the census data I looked at shows that we're about 10% of the population. And so it would make sense that we are 10% of the infections or the cases in Alameda County. But the problem is that we represent 18% of the deaths. So we're almost doubly overrepresented in death in Alameda County from COVID. So what are some of the potential explanations for the death rates and the burden specifically of death in Alameda County Black residents? So there's a, it's multifactorial, of course, and there are some parts that happen on the individual level, but then there are some other pieces that happen on the system level. And I think, I've been doing disparities work for almost 30 years now, and so much of the literature in the 90s was always about what the individuals were doing wrong, especially if it was about Black people. And that, relates back more to my work in cancer, but it was always like the fault of Black people for making bad choices or not taking care of themselves. And there was never a self-reflection on the system. So of course, there's, the issue of masking, but there's also the issue of isolation and whether or not you're able to isolate. And I'm going to speak to that in a second. And then there is, the individual choices that we make to reduce the severity of COVID-19. And so that includes vaccination and booster uptake. But then on the system level, we have issues of access. And I think we just heard that in the mental health panel as well. And here we're talking about access to oral therapies, including Paxlovid, as well as the IV therapies, those monoclonal antibodies that are not particularly easy to get. And then also some issues around timely hospital admission. And I am going to speak a bit to that just in terms of race, racial bias, as well as racism in healthcare, because that's also having an impact. So talking about whether or not you're able to isolate, I think it became very clear at the beginning of the pandemic, like the people who could go home and work from home and be in front of their computer all day and not miss a beat were the people who were protected from the pandemic. But as I think we've come to learn that, the majority of frontline and essential workers are disproportionately show representation from African-American people. And of course, these are jobs that involve face-to-face contact where social distancing is impossible. And I've just listed a few of the categories that I think where we see our African-American community in Alameda County working in these essential and frontline jobs. A colleague of mine at UCSF published on the excess deaths in essential workers from COVID-19 in 2021. And what you'll see is some of the job areas that I had listed previously, including working in food service, as well as working in facilities or cleaning, and working in transportation and logistics. Those are folks who had big spikes, and the spikes that I want you to pay attention to are the ones in pink. Those are essential worker mortality or death from COVID in 2021, as compared to non-essential workers in the blue line. So you can see very clearly that there is a disadvantage to having been an essential worker during the pandemic. And that's not about making choices, obviously. So I want to talk about vaccination just briefly and share with you on the left. This is the percent of populations that have completed the primary series. So the first and second shot, or with Johnson & Johnson, just one shot. And the blue line is at least one dose that has been administered. And then the yellow line represents both doses in the series or completion, as I had just mentioned. And what you can see is that for African-American people in Alameda County, there's a lower rate of having both vaccines as compared even to other populations of color. On the right-hand side, we're now talking about boosters, because at this point, if you've only had first and second dose, you're really not up to date. And we know that these boosters do make a difference because the immunity goes down over time. And so what you can see again is that there is a slight lag for African-American community in Alameda County in terms of having gotten the first booster when it was recommended back in September of 2021 at 31%, and then the second booster at 44%. There are other communities that have low rates as well, but for African-American community, we have typically had close to the lowest rates of vaccine uptake through the course of the pandemic. Now I want to talk about racial bias and racism in healthcare. And I'm sure you've been hearing a lot about all this in the news. the racial disparities in the pulse ox device. That is the device that is used to measure the oxygen level in a person's blood. So when you come into the emergency room and you're feeling short of breath potentially, and maybe are sick with COVID, we use these devices to determine a cutoff point. So if your oxygen level is below somewhere in the 92 to 94 range, then you will automatically be admitted. That was an indication for admission at the beginning of the pandemic. If you're above that level, then you would not be typically admitted, especially if the hospital is crowded, and you know what happens when healthcare is rationed and there are Black people involved. Generally speaking, the rations don't come to us. But a lot of papers have been published, I mean, even as far back as 2018, I believe, showing that these devices, which send an infrared signal through the fingernail from one side of the device to the other side of the device, it's a clip that goes on your finger, that it may actually have difficulty in accurately reading the oxygen level in people who have more pigmentation in their skin. And so some folks, once the pandemic started, including Dr. Noha, who you'll hear from later, really were questioning this issue that I had raised in the beginning, that there are a lot more deaths in Black people. It's not really about the cases, it's about the deaths. And so we started to kind of try to dig into some data from California to figure out, you know, what is actually going on at the hospital and healthcare level. And this paper evolved out of a collaboration with Sutter Health. So this really does represent Northern California patients, over 40,000 of them, who had a pulse ox reading as well as a blood gas draw. So the blood gas is the gold standard. That tells you what the oxygenation level really is. And what we found was that systematically, Black people in 2020, during the beginning of the pandemic, when this was the main criteria for admission to the hospital, were having their oxygen levels systematically overestimated, which means they would be sent home rather than be admitted. And what we did find was that there were some delays in care in the delivery of supplemental oxygen, because of course the pulse oximeter is telling us that the oxygen level is fine. And then there were also delays in other kinds of treatments that were administered. So this is no small matter, because this device is used in every single hospital that you will ever walk into, and many clinics as well. Then I want to point to this, this report that was just published by the California Healthcare. Maybe I've heard something about it in the news, about listening to Black Californians. Over 3,000 Black Californians were surveyed, and I think the two striking findings that are just in stark contrast to each other and stand in the way of Black people actually achieving their best health is that that 75% of the people surveyed said that they were very intentional about pursuing mental and physical health services and wanted to do primary care screenings, et cetera. But nearly 1 in 3 had been treated unfairly because of race, ethnicity, and then 1 in 4 or more actually avoided care because of their concern about potentially being unfairly treated. And I think this really speaks volumes, because the literature of the 90s, as I mentioned before, you say, well, you're not taking care of yourself, you're making bad decisions, and that's why the outcomes are bad. When in reality, it may be the case that, and I think a lot of us know from firsthand experience that it is the case, that why would you want to enter into a space that's about health, where what you're going to be met with right away is a judgment and then blame about why you're having the health problem that you're having. So it really is, health system is getting in the way actually of Black people achieving their highest goal. So I want to talk a little bit about what we did in partnership with Alameda County Public Health Department. I really want to acknowledge the Public Health Department for being as open as they are. I just will note that we work with 3 different public health departments across the Bay Area, and Alameda County has been the most open to hearing community voices, trying to respond to community voices, and partnering to get to health equity. And so I want to start with Baba Arnold Perkins, who used to be the department, the director of the public health department, And he is now works closely with us as the chair of the Community Advisory Board for the Cancer Center. And he's got these great quotes that really are so simple and basic, but they really encapsulate like what we're not doing, what we should be doing, and just have that just touch of wisdom that I always like to incorporate into my talks. So one of my favorites is, after all is said and done, a lot more is said than done. And I think we talk a lot about equity, but it's unclear what we're actually going to do about it. So when the Public Health Department reached out to UCSF early in the pandemic to get resources and bring testing into communities that had not been able to access it. You may remember there were no swabs, there was no reagents. You had to have the 3 specific criteria in order to get a test. I mean, it was ridiculous how we were keeping people from actually knowing that they have COVID so that they could mitigate the spread. When we came over to Alameda County, and we're really focused in Deep East Oakland, what we observed was that the places where there were high rates of infections, which is indicated here in the dark zip codes, were not the places necessarily where people were taking up tests. So you can see it's kind of lighter here. And you can see that by contrast, and I want to point out sort of by privilege, that all of the testing was happening in zip codes where there wasn't a lot of infection. And so our goal was actually to increase the testing participation of African American people and really just get African American folks in the Bay Area engaged with the process of testing for COVID, being aware of COVID, understanding what can be done about mitigation without being, pedantic, without kind of lecturing to people, but instead including them in the process of being part of the solution. And so what arose out of that is Umoja Health, which is I would say the East Bay version of United in Health, which was started in the mission under the title Unidos en Salud. There have been a number of franchises of United in Health, and each community gets to name its own. And the community partners you see here on this slide that have grown over the course of the last 2.5 years, that still continue to meet together, supported by the Public Health Department, as well as some resources from the UCSF Cancer Center, where I work, have come together to ensure that people get accurate information. And we do that on an every other weekly basis at this point. So this group chose the name Umoja Health, and I just will give you a little inside scoop. The Umoja symbol, which looks like an X, was actually going to be the center of what was going to be called 40 by 40. But there weren't enough people who knew exactly where the 40 by 40 is, and maybe Dr. Noha will tell you a little more about the 40 by 40 when she talks. But so what we decided to do is drop the 40 and the 40 and just have it as Umoja Health. And it really refers, as many of you know, Umoja means unity in Swahili. It refers to the oneness. It's really about a unified mission or a goal. And all of these organizations, even though they probably hadn't worked together in this format before, came together under that unified mission. Another quote from Baba Arnold is that you can't teach what you don't know, and you can't lead where you won't go. And I think this really refers to proximity fear. And I'm sure some of you know exactly what I'm talking about when I say proximity fear. Institutions are afraid of Black communities. They're afraid to be in them. They're afraid to be near the people. And I really think that that quote from Arnold really reflects on that point, that we really don't speak very explicitly, but I want to say it here because I want to acknowledge that it's a barrier. So what we did was we asked the Public Health Department to give us a map and show us where are Black and African American people living. Because what we realized is if we stayed in Deep East Oakland, we were going to miss these communities here in West Oakland. And for me, it really pointed out the history of Black people in this country. We are not immigrants, right? So what that, and our history as slaves is being brought to this land and being separated and dispersed. We're not moving here and then going where Tia lives, right? We're here and then we're dispersed. Families are spread apart across the Bay Area. So we wanted to know, where all do we need to be? Because if we stay down here or if we pick only one location, we're not going to be able to reach everybody. So what we started doing was really the first pop-ups for COVID services that ever happened in Alameda County. We partnered with the Acoma Market. They were going to have their opening on September 6th, so that seemed to dovetail really nicely. And we knew that that was a market that was by and for African American people, and so we knew that that's where people were going to be. And so we said, we're going to pop up there. But before we pop up there, we're going to send out our street team. And that's going to be led by some of our youth who are going to take our collateral that was designed by and for us, is screaming, this is, for African American people. And we weren't pressuring people. We're just letting them know so we could answer questions about COVID. And then let them know that there was going to be an opportunity to get tested for free if they wanted to. At the time, we're also checking antibodies because a lot of people thought they had COVID. And that was a way to mobilize folks to our site. So you can see by the green dots here where we showed up in the community. And really, we do everything outside under tents, rain or shine, rain or shine. So we did a little survey data, and I'm going to breeze through this really quickly because I think it all comes together to make a point. First of all, at this time, early in the pandemic, over half of our participants were first-time testers. And then when we asked who are the first-time testers, you see that the majority of the first-time testers were Black or African American. When we came back after this first go-round in the fall to pop-up testing again after taking a break through the winter of 2020 into 2021, the Black participants were no longer first-time testers, and that we thought that was really cool. The public health department also shared with us that at the time we started organizing, having meetings, talking about COVID and popping up these events, that African Americans became the highest rate of COVID-19 testers in terms of the uptake. Now, that's not because they were getting their tests with us. It's because we think that we were influencing people and changing attitudes about testing, and that it wasn't going to be the delivery of COVID into your nose with the nasal swab. I will also say that we got rid of the nasal swab and started using saliva-based testing because we knew our community was having some issues and some concerns about that. So again, just very much centering the African American experience with healthcare. So then the other thing that was surprising is we were asking people, are you willing to be contacted for additional research? And we didn't have any additional research planned, but we were shocked to see that the highest rate of folks who were saying yes were African American people. We also asked if people were willing to take the vaccine at the time. You can see that the interest was relatively low for African American people, but when you compare that to what was going on in the country, we were exceeding that. And we thought that that was sort of an endorsement of how people were trusting us, because not only did we show up once, but we kept showing up over and over, and we kept having meetings, and we kept giving the data back, and we kept incorporating people into delivering the services. And that prompted Alameda County to give Umoja Health its own vaccine allocation. So we were the only community collaborative, community-based anything to be handed vaccine and be allowed to deliver it. And we did that with a volunteer workforce. And you can see some of the pictures here. We partnered with churches, we partnered with local health fairs, and street fairs and street parties, block parties, because we just wanted to be where Black people were. We didn't want them to have to come to us. And we also wanted to come in an unintrusive way. Like, you could be here for the block party and, oh, you just happen to have an opportunity to get a vaccine or to get some information or to talk about your cancer because there's a doctor on site, one or more, who will be willing to answer those questions for you. And I think that's the kind of access people really want, is answers now, not an appointment in 6 weeks when my problem is resolved. So we have delivered as a community coalition. So this is volunteers putting shots in arms. And I'm sorry, I just want to go back for 1 second. I want to say something about AJ, because AJ joined us as a community mobilizer, but over the course of the 2.5 years of the pandemic, he has gone to medical assistant school. He's taken all of his tests. He's now certified, and he now vaccinates at our sites. And I think that's another thing that can be achieved when you create an environment where the people are part of the solution. So we always were checking like what proportion of our vaccines are going to African American people. We continue to stay above 50%. When I think whenever you roll out a low barrier or no barrier opportunity, you tend to see other communities start to show up. But we are very faithful in trying to ensure that our resources reach the Black community in Alameda County. And I just do want to point out that I think in the beginning I showed you that African American people are at the lowest rate of uptake of vaccines at this point. And it might seem, I think from this myopic view of just looking at Alameda County, you might think that's terrible. But if you go and look at the dashboard in Los Angeles, you will see that the African American community has, in terms of completing this first series of vaccines, is still down in the 60% level. So actually what we're doing in Alameda County by bringing together
You lost your audio, Kim. Hey, Dr. Rhoads, can you hear us?
Yeah, frozen.
Yeah, we
Frozen and
lost
no
your
sound for
audio,
everybody.
Dr. Rhoads.
Wow. Well, that was amazing.
Well, I'm going to text her and see.
sorry, can you hear me?
Yes.
Can you hear me?
Okay, she's back.
Yes, we can hear you now.
Okay. So I was making the
we
point
can hear
that
you
Alameda
now.
County. Okay, thanks. Sorry about that. Alameda County has a higher rate of vaccine uptake in the African American community than a lot of other cities and counties in California that have large populations of African people. I think that's a testament to Alameda County's willingness to sort of engage in this effort to have communities really be part of the solution. So I just want to end by saying that another quote from Baba Arnold: if you want to have what you've never had before, you have to do what you have never done before. Effectively, you have to disrupt the status quo and flip things on its ear. So we recognize that trust builds at the pace of the relationship, and that's also different, right? When we started vaccines, like, how do we gain trust? Well, you don't. If you don't have a relationship, you shouldn't expect to have any trust. We build trust by sticking around, by continuing to show up week after week after week for 2.5 years, and then by moving into other spaces to provide care around other issues, including cancer and diabetes. So we think the approach works because we're always taking action. We're not just talking about it. We're centering Black experiences in Alameda County in order to deliver something that looks different than what people have traditionally experienced. We have deep community engagement. It means the people are embedded in the process of the solution. And the education is not coming through a lecture, it's coming through participation. And then, as I said, we have ongoing meetings. We always share the data back. There is no hiding of data. And we adjust our approaches as recommended by our community partners. So the last thing I just threw this slide on here as I was listening to the previous panel, just making the point that it is true that the public health departments have had to, I think for political reasons, go along with the CDC, which is effectively going along with President Biden, who said the pandemic is over. We all know the pandemic's not over, but we also know that as essential workers, we are the ones who are actually going to be further damaged by folks acting like the pandemic is over. So we decided as a coalition, and I just will say we have spread to San Mateo. So there's Umoja San Mateo, Umoja San Francisco, and Umoja the town, the original. That we worked together to develop this messaging for our people. And these messages, if you ride BART, you'll see them all over BART. There's about 300 of them distributed all over. Keep your eyes peeled also in the 12th Street BART station. We have the digital boards, as well as the big billboard on I-80 outside of the Coliseum. And really the decision was just to take the messaging into our own hands to protect ourselves. And, you know, what we do know is that the Public Health Department, Dr. Moss, Director Watkins Tart, you know, have changed their calendar to accommodate their ability to be at the Umoja meetings, because that's where the people are. And they do listen very closely to what folks are recommending. They're limited in what they can do on messaging, but they did not try to stop us on the messaging that we put together. And in fact, are willing to provide, you know, whatever data or information that we need to ensure that that messaging is accurate. So I want to thank you for your time and attention. And again, the big message here is that people need to be part of the solution, because when they are, their commitment to making it work is much better. And we are not, as institutionalists, we are not the experts on everything. In fact, we have so much to learn from people living real lives so that we can create interventions that actually center real people's experiences, not the theoretical frameworks that we think are driving the outcomes that we see in our communities. So thank you.
Thank you, Dr. Rhoads. I don't know about anybody else, but I took notes over here. I was trying to catch all of the gems. Also, thank you for, you know, connecting the dots for us. You know, we went through this experience, and, you know, to know that, you know, we had people doing the work and asking the questions that we didn't even know to ask at the time, you know, and then, you know, just have this in a wonderful presentation. This is wonderful. So we want to know how we can get involved with Umoja Health. That is question number one.
Yeah, so if you go to our website, it depends on where you're located or where you want to volunteer. Currently, under the communities we serve, it's just Alameda County, San Mateo, and San Francisco. So anywhere on any of the home pages, if you see Alameda, San Mateo, San Francisco, you can click that button. You'll go to a specific page that is for that community or that county. At the bottom of that page, it'll say volunteer with us. And so there's a link where you can volunteer. Personally, I think, you know, it's great to volunteer and it's great to come out and deliver direct service. But I also think it's really important to get the information. So you can join our meetings, and that's again at the bottom of each of those pages. It says under resources, get an request an invitation to our meetings. That's where you're going to get information that is, you know, public health department might give you what's on the dashboard, what does the data look like, but then what's happening in those meetings is we're asking questions that specifically focus on the experience of Black people. So yeah, the data looks like that, but what does that mean for us? And also, we're always trying to look ahead and help people prepare, because this COVID is over. Yeah, it's on break, and it goes on break intermittently, right? But we know that more is coming. So what do we need to do next? Stock up on masks, stock up on your rapid tests, have a plan for how you're going to get Paxlovid. And I do prescriptions for people who don't have another way to get Paxlovid quickly. I do that in collaboration with Dr. Noha, because sometimes the system gets in the way of my ability to do it, despite the fact that I have a full medical license and liability, et cetera. So, you know, at some point we'll really have to talk about like all of the different system barriers. But what I will say for this group now, please get involved. Please get on one of these meetings. Please learn how to look at your local dashboard, because what's coming for the winter is going to be very scary, partly because all of the federal funding is going away. That federal funding goes to the states, goes to your local public health departments. So it's going to be gone. And so you need to start to get prepared about how you're going to get access to resources that used to be free that are now no longer going to be free or readily available. So please join us on one of our meetings in any jurisdiction. You'll get pretty much the same experience.
Okay. So we have a quick question from the audience. As a provider, how has COVID-19 impacted Black cancer patients trying to receive quality care?
Well, I've published a lot in this space around Black cancer patients in California receiving quality care. So that's already by itself, it's its own barrier. I think what COVID has done is it scared people away from getting screened or getting in-person appointments. And so what we're seeing now is more advanced cancers. And as you know, when we see advanced cancers in African-American communities, that translates into disparate outcomes, worse outcomes. And so that's why you saw that one poster in the middle. It said, cancer is not waiting for the pandemic to end. So we really do want to continue to encourage people to continue to get screened. I do through Umoja now because people feel like they have a portal of entry into our UCSF Cancer Center, help people get second opinions, help people get that kind of fast access that they're looking for, not an appointment in 6 months, but directly into some folks' clinics. And I just am leveraging my longevity at UCSF. I trained there as a surgeon. I trained there in colorectal surgery. I trained there in health policy. I went to medical school. So I know a lot of people. And in my role as the director of community engagement, I really can just pick up the phone and say, one of our community partners needs something. And I think that's, Kamara Jones described that as making the barrier between the institution and the community more porous. And I'm all for that. And so I see myself as bringing the portal of entry closer to the people. So that's one way I think that, as I recruit more physicians into this work from our institution, that portal is just going to get bigger. So if you need help, you can get it through Umoja.
Wonderful. Okay, so another quick audience question here. We're seeing a decrease in Black medical professionals in the health system. Has there been a push or thoughts to create a program for African Americans to get them into the medical profession so that we can see people that represent us? This is a big one.
Yeah, so actually, there are parts of Umoja that I didn't talk about. If you go to the website, you'll see them. But one piece of it is workforce diversity and workforce development. We, in partnership with Rhoads and Marcus Foster Education Institute, we put together a program called the Umoja Health Workforce Summer Interns Program, where what we're trying to do is expose young people, mostly so far from Deep East Oakland, mostly first generation going to college, a lot of them from immigrant families, really the people you're not going to see inside of healthcare. We're trying to bring them through, and in the 6 weeks in the summer, with a stipend and a computer, we're trying to prepare them for college, number one. Number two, if they're planning to go into the medical field, we're trying to prepare them for structural racism and the interpersonal racism that they're going to see inside systems that were not designed for them, sometimes don't want them there and don't necessarily want them to succeed. Because in my experience, and I think I probably speak for Dr. Noha as well, you could spend a lot of time trying to figure out, is what just happened, is that racism, right? And be all torn up about it, and then maybe think that you're not good enough. And one of the things I want to really help these young people understand is, yeah, it is racism. You've got to move on, at least for now, because the system isn't ready for us. We need to develop critical mass. And so not to spend that extra energy that takes away from your ability to concentrate and study and take care of your patients and do well, but to prepare them that this is what you're going to see. Because I think folks have the false impression that you walk through the door and everybody's suddenly very objective and you don't have to worry about racism. And if you thought it was racism, it's probably just a misunderstanding. No, it's racism. So we do that piece, and then after they finish with us, they get funneled into some kind of work that is also going to enhance their career. So we've got 2 people at Exelexis, 1 at Genentech, one in nursing school, one applying for nursing school. And I mentioned AJ because he's really the first, Umoja Health workforce. He wasn't a summer intern, but the idea, the concept that we could use this as a way to start to train people and prepare them for diversifying the healthcare workforce. He was really the inspiration for that. And then the second program that we have is called the Umoja Health Youth Mobilizers Crew. These guys are 18 to 30 years old. We do that in collaboration with Roots, with Reverend Cheryl Ward's Liberation Ministries, with Youth Uprising, with the Black Cultural Zone, and Marcus Foster. And what we were trying to develop are voices that hopefully the public health department will consider integrating into their regular workforce, because youth voices could be leveraged for teen pregnancy, STIs, like a lot of the work that goes into public health, early on. And so what these young people are doing is they're running our social media, which is good because I'm don't know a lot about anything besides Twitter, which now I think is for old people. And they are creating messaging. For example, they did some PSAs last winter to talk about masking and being careful and avoiding crowded spaces, etc. They're about to embark on another project where they'll be doing air quality monitoring in different businesses where they frequent and posting on social media. Is this place safe, or do you need to be wearing a mask? So of those folks, we've had one's just start as a freshman in college. And then we've got other volunteers who are kind of young people who are on their way somewhere. We have one student who is an MD PhD at the University of North Carolina, where he's trying to start an Umoja movement as part of his PhD work. So we are working on workforce development and workforce diversity, absolutely.
Wow. Well, Dr. Rhoads, we could listen to you all day long. Thank you so much for this information. Thank you for giving us opportunities to find out more about Umoja Health. And folks are requesting your presence in the chat now to answer a few more questions.
Okay.
So yeah, that was awesome. Thank you so much.